So welcome to the Central South Stroke Network's Fall Education Series focusing on stroke and the young patient. Today's webinar is the 6th in our series, and it will be recorded and posted to our Central South website. There is the Q&A function at the bottom of the screen, so please use that. Some questions may be addressed as the presentation goes on, but there will be time at the end for questions. So as Regional Education Coordinator, I have the privilege of introducing our speaker, April van der Veen. April has worked as an occupational therapist on the Integrated Stroke Unit at Grand River Hospital since 2013. April is also a PhD student at the University of Western Ontario in the Faculty of Health and Rehabilitation Sciences.
Thank you so much for that introduction.
Yeah. Sorry, there's a code here, but I'll continue. Her research interests include addressing driving in the acute care context and return to driving after stroke. So welcome, April.
Thank you so much. Thank you everyone for tuning in today. And please, if there's any questions that come up throughout the presentation, please feel free to ask them at any time. So we will just get started. So for today's session, I'm hoping we can do a brief review of the stroke best practice guidelines for stroke as well as TIA. We'll do a brief overview of some legal and professional responsibilities and reporting drivers to the Ministry of Transportation. And then we're going to review some practical strategies to know when and how to address driving. We're also going to discuss condition reports, how they're completed and what happens after one's done. And then we're going to have an opportunity for some interactive case discussion where I'm going to put some details of a case, and there's going to be some multiple choice questions, and it'll be based on the content that we're discussing here today. So I wanted to begin with a quick little knowledge test just to see where people are starting. So I have a Zoom poll that I've asked Tina to launch, and I'd like you to please take some time and review these true and false questions. So I'll let you read those through. Is anyone having trouble accessing the poll, or is it all working okay? Thumbs up. Okay, great. Some responses are starting to come in. Wonderful. Okay, I'll wait until we've got just a few more respondents, and I'll end the poll, just in interest of time. But and Tina, is there a way to save the poll? Oh, share the results. Okay. So how do I? Okay, so the first one here, following stroke or TIA, a patient cannot drive for 30 days. So we had a lot of people saying true, and we'll come back to these later. A condition report must be sent to the MTO after a patient has a stroke. Again, looks like we're divided here, not as decisive as the first question there. Is everyone else able to see these okay? Someone let me know.
Yes, I'm sharing it, so
okay,
everyone will
wonderful.
be able to see
Okay,
it.
Great. Okay, looks like we're pretty decided on question 3. And then again, we're a little bit unsure about these. Is there a way we can save this so we can talk about it at the end, Tina?
Yes.
Maybe a screenshot?
Yes, I'm writing down the numbers for sure, but we will
perfect.
To replay us. Yes.
Great. Okay, thank you so much. Can I just close this now, Tina?
Yes.
Wonderful. Okay, thank you for participating in that little exercise. Okay. So best practice guidelines. So for stroke, and these are in accordance with, so the Canadian Stroke Best Practice Guidelines, which are informed by the CCMTA, which is the Canadian Council for Motor Transit or transport administrators, which they deliberately did to make it a mouthful. And so it's based on sort of the national driver standards as well as the stroke best practice guidelines. So following stroke, no driving for 30 days, and they additionally must have no residual deficits that impact fitness to drive. So I'll sometimes say to my patients that you could be doing cartwheels, backflips. If you've had a stroke, you need to abstain from driving for 30 days. And another best practice about that is if we do need to inform the ministry about a stroke, we need to, the best practice is to inform the patient of that personally and directly. In the case of TIA, there is not a specific rule for how much time you need to abstain from driving, and it really has to do with their functional and medical presentation. So in the case where it's a true TIA, the symptoms, are by definition transient and have recovered completely. There is no specific time frame for driving. It's really about, is there a medical risk of recurrence or sudden incapacitation? So if they were admitted with rapid AFib and that was the risk factor that led for them to have their TIA, is that AFib under control? Do they have the right management plan? So the TIA, it is dependent on that risk of recurrence, where with stroke, if they've had a cortical stroke, they need to abstain for 30 days. Okay, so touching on legal and professional responsibilities, I find it useful to think about different facets of fitness to drive. So when we think of medical fitness to drive, we think those are the medical conditions and their associated impairments that impact fitness to drive. And this really is about, are there medical conditions that aren't managed that could cause a risk for sudden incapacitation, or are these conditions causing impairments that can reduce the risk of driving? So the great example is a TIA. Are the medical risk factors for a recurrent episode under control? Are there medical reasons they can't drive? So a seizure would be another medical reason not to drive. And then within the allied health group, functional fitness to drive is where I think myself as an OT, I think this is where my expertise lives, is thinking about what functional impairments impact fitness to drive. And I like to think about this as, do they have the sufficient cognitive, sensory, visual, and motor skills to operate a vehicle? And I find that this is a helpful way to think about fitness to drive, and it can help you understand what your role is. And so, certainly we look to our physicians, optometrists, nurse practitioners for those medical components, and the functional ones, we look at occupational therapists and of course our valued other allied health team members to make contributions to this. And I find that can help with role delineation when you have a question. Is this about medical fitness? Is there a medical issue that might prevent them from driving? Are their blood sugars under control? Those sorts of things. Or is this a functional question? Do they have sufficient coordination? How is their cognition? That might be a functional fitness to drive. And I think that can help with making decisions about who needs to be at the table to support these decisions. So in terms of our responsibilities to the ministry, mandatory reporters include physicians, nurse practitioners, and optometrists for just the vision conditions. And that means that they have a legal obligation to file a report if an individual has or appears to have an impairment or a condition that would influence driving ability. So in the case of a mandatory report being sent by our physician colleagues, that generally is more likely to result in automatic suspension. So if a mandatory report is sent and there is no other information sent to kind of assuage the concern that's had about that medical condition, it will be a automatic suspension. But if there's a medical issue that comes up that resolves and more information can be sent, that decision can be reversed and the license is maintained. So sometimes what will happen with these forms at the ministry, if a mandatory report is sent and there's some degree of uncertainty about the information, they'll often ask that family physician usually to provide a bit more information. And if that information satisfies the driver standards, they won't suspend the license. But by and large, an automatic suspension follows a mandatory report being sent. So discretionary reporting is also for physicians, nurse practitioners, and optometrists, but it also includes occupational therapists as of 2018. So individuals with this reporting authority, they may submit a report, but they're not legally required to do so. There certainly can be ethical and professional responsibilities to do so, but no one can come after my license in the same way that someone can come after a physician's license. So what happens is a discretionary report is sent. There's a different section on the form that's completed, and I'll discuss that. And you provide information about the condition or the impairments that are observed. And then it's, again, reviewed against the national medical standards that every report is given to someone to review the report and the driver standards to make a recommendation if more information is needed, or if there's actually sufficient information to warrant a suspension. So in these cases, it's a possible suspension when it's a discretionary report. One thing that's important to keep in mind is that when we've made a report in good faith, there's no negative consequence that can come to us. If we've observed that patient, we know them, there's no conflict of interest, and we would, to the best of our knowledge, made an informed report, we cannot be sued by the patient. This is designed to protect practitioners, to keep patients and, of course, the public safe. And another important thing to think about is that it is also the MTO that is making this final decision. What we're determining is, do we need the administrator to rule in and make a decision? We're not determining driver fitness. We're just determining if they need to weigh in and make a decision. So I think that can help with understanding the role between the practitioner as well as the Ministry of Transportation. So when I talk about addressing driving, what I really mean is two separate things. And so, and there's different roles and responsibilities for each of these. So when I think of addressing driving, I think about providing education in one side, which I think the whole team has a very active role in doing this. Patients ask about this all the time, and with stroke in the young, it's a primary rehabilitation goal. It's, it's always something that comes up very high in all the research, the importance of driving for the patients after stroke. So if the whole team has some education that they've taken themselves to be able to share with the patient, that's very valuable. And then the other part of addressing driving is actually making a fitness to drive recommendation. So this might mean making some driver screening. It might mean deciding if a ministry report needs to be sent. So I try to think about those two different components of how we address driving, providing education, but also providing recommendations. Okay, so we're going to first discuss providing education. Okay, so when to provide education, really any time during the stroke care continuum. I find that this is an easier thing to know when the right thing to do is, because providing education is something that we can all be involved, and patients often organically bring it up. And so I think that this is something that you can use your clinical judgment, but a very natural point I find is during discharge planning and goal setting. I usually wait for it to come up organically if I can, because it can be sort of overwhelming for people, but I find that this is one that generally any time during the stroke care continuum is a good opportunity to provide education. So how to provide education. So what I recommend, and certainly what Stroke Best Practices recommends, is informing the patient of stroke and TIA driver restrictions. And a handout is excellent, and I have an example in the next slide. I find that they're overwhelmed, particularly when I see them in acute care, and providing that in written format is, I think, very useful. I also think it's really important to provide very active support when it comes to accessing transportation alternatives. And what I mean by that is not just saying, take a taxi, provide them with information about this is the taxi number, these are volunteer drivers, this is how much it costs, and just making it as accessible as possible. This is, patients are met with incredible stress when trying to navigate how to get around without a vehicle in our incredibly car dependent cultures. So I think that making a very patient-specific, location-specific handout is very helpful for that. Also, not being able to drive causes considerable stress on the patient. Research time and time again has showed that driving is associated with autonomy and independence, and it facilitates social interactions, engagement in valued occupations and activities. And offering support is something that's very valuable. So this next slide here, this first link here is to a really great resource that was a handout developed by another stroke network that has wonderful education about return to driving that you can access this link to share with your patients. And then I also, so if you go to the Healthline website here, this is a way that you can develop your own localized, personalized transportation alternatives. The website's very easy to navigate, and you can include everything from driver assessment centers to where to get accessible parking permits and volunteer drivers. I really recommend you make a personal one for your catchment area of the patients you serve. And then after stroke is another great resource for patients that are coping with difficulties after stroke and might need some support about dealing with driver cessation. So I recommend this, this service as well. Okay, the next part, this is a little bit of the trickier part. We're going to discuss providing fitness to drive recommendations. So the when for this is a little bit more challenging. And I think that it's difficult because it really depends. It depends on the patient presentation, their journey through the continuum, et cetera. So, you know, you might approach driving differently for a patient who's leaving acute care and going home versus someone going to rehab. And I think that it's also important to acknowledge that this is something that we all have different thresholds for our comfort with addressing this and what we think needs to be, you know, a condition report sent and what means, oh, maybe we'll see how they do. So I think that as a clinician, it's difficult as well. So not only is it difficult because the patients have different presentations, but it's also difficult because we have different thresholds as all of us. And I think acknowledging that we all have different comfort with this is helpful to try to think about, you know, and reflect about your position on this and get more education to help you with your decision making. So despite these nuances, I think that there are some general considerations that can help. So Stroke Best Practice Guidelines says that they want us to make these determinations at transitions and follow-up visits. The previous guideline said wait 30 days. And I have a suspicion that the reason that was the case is they wanted to see how, you know, people recover from stroke, what their response to rehab is, and so on. But it makes sense for it to be at transitions and follow-ups, which really makes it, you know, encouraging people anytime along the continuum to feel that they can assess it and not just at that 30-day mark. And myself from acute care, I mean, I have patients and stroke in the young, they might come in, they've had EVT, they've had a good response, and they go home and I'm not seeing them in 30 days and I'm not going to do follow-up. So then it kind of left us in this weird, you know, well, when should we address it? I'm not going to address it in 30 days. So maybe we actually need to address it now. So I have a suspicion that transitions and follow-ups is trying to give, you know, more flexibility for people to address it when it makes clinically sense. But I want to encourage everyone to think about, when possible, can we reserve decision-making when we have a reasonable expectation for their new functional baseline? Sometimes we don't have this luxury. Sometimes we haven't been able to make, you know, in acute care, sometimes they've discharged right away and we've just got to make a decision, or we have some risk. We've concerned that they might drive against medical advice. Sometimes we need to just make a decision, and maybe that means sending a condition report. But when it's possible, I'd like to suggest that we try to do make our determinations about whether a condition report needs to be sent, whether they need driver screening, when we have some expectation of their baseline. So or of their new expected baseline. So a good opportunity is when they're transitioning from home or to the community. And from acute care, especially if we're the last stop, if they're going home and we're not going to have any other therapy follow-up, I think that's a time when we need to consider, do they need assessment? Do they need screening? Do we need a ministry referral? And then again, prior to discharge from inpatient and outpatient rehab settings, that's a time, if it hasn't been addressed already, let's think about making a recommendation, making sure that education has been provided as well. Another opportunity that forces us to make a decision is if there's concerns that the client will drive against medical advice. Sometimes they're known concerns, sometimes they're ones that we have to infer based on context. I have had some patients tell me that, well, I'll be driving anyway. And so, they've been quite upfront, but sometimes we need to use our detective skills and figure out where is the risk and, involve the team, make a team decision. But I think that's a time when we need to rule in, make a decision. And then another time where it might make sense is that when our clinical judgment tells us that it's very unlikely for the patient to regain the functional ability, medical status to return to driving, and they're just going to need a referral to the MTO. And even if they are going to, potentially recover later, they're going to need to go through a functional assessment process anyway. And so maybe we just need to send a referral, make a determination, and possibly send a report to the MTO. So there's exceptions to all of these rules, but these are some guidelines that I hope will find helpful for when do we make some decisions about this? When can we possibly do screening? When should we consider sending an MTO report? So in terms of how to make fitness to drive recommendations, this is also another challenging one. And again, I think it depends on your time you have with the patient, what resources you have available to you, who's on your team. There's quite a lot of factors, but again, I'm going to go over some general things to consider. Again, I want to highlight that is the MTO that determines driver fitness. What we need to do is determine if the MTO needs to weigh in. Just a general point again about the when is making sure that the diagnosis is clear before we decide to make some recommendations about fitness to drive. The rules are different for stroke and TIA. This is usually an acute care issue where we'll have patients first 2 CTs are negative, we're waiting for that MR to confirm if it's a stroke or TIA. I find it's very helpful when possible to wait until that diagnosis is very clear. I know sometimes it's challenging and I don't know if other people find this, but sometimes from acute care, I'll have a patient that, they're going to be going home after their MRI is read, and that might not be until I've finished my shift. And so we're forced to make a decision, but when there's time, we can try to wait for that diagnosis to be clear. Oh, do I have a question?
Finish your slide, April, and then I just wanted
okay.
to
Sure.
there was a question. Yeah.
Thank you. And then the next thing is that making sure again that you're doing this at the right time. So especially from acute care, have you ruled out that no further therapy is indicated? If you have an expectation that the patient's symptoms are mild and expected to improve, when possible, we want to reserve our judgment for that time. So if you're going to be doing OT follow-up, we might do something different than if they're not. And so making sure you've, done some cognitive assessment before you go to make recommendations is important. Because what if you just jump into, they seem fine. I've done a, cursory functional assessment. You jump in and you do some driver screening tests and they have impairment. You're thinking, oh, is this something that actually needs outpatient follow-up? So make sure you've, done a thorough assessment before you move on. Okay, I'm ready to answer that question there.
Perfect. So it's Silva. Hello, thank you for the great presentation. What type of panel makes the final determination at the MTO? Are they OTs, optometrists, physiatrists?
Yes, so it goes to someone who has, I believe, it goes to someone who is trained in how to review all of the medical standards. I do not think that it is a medical professional that makes that decision. So when there's a very clear problem with, if it's not very apparent based on the report that they're given, that the patient is meeting the driver standards, that's when it will go to the functional assessment. And so then that would be with a so it would be with an occupational therapist and a driving instructor. There's another slide later that I'll be able to discuss that further with what professionals are involved with making these decisions. But that's a great question. Thank you so much for that question. Okay, so for screening tests, I have some bad news and some good news. The bad news is that there's no one test that is going to, be this, silver bullet that's going to help us answer this question. But the good news is there's some options that I can share with you. And this is, these recommendations here are right from the Canadian best practice guidelines. So they're recommending assessing cognition, sensory perceptual skills, and motor skills. And in fact, they're recommending this order of assessment. The reason for that is if you think about the different performance components that a patient can present with, do they have impaired vision? Do they have impaired decision-making? Do they have some incoordination? That how it's ordered represents the risk of motor vehicle collision. So cognition is the greatest predictor of impaired cognition is the greatest predictor of motor vehicle collision. So they are recommending we start with the highest risk and then move on. And that makes sense. And I think that it's important to also acknowledge that if we're saying that a patient needs to have sufficient cognition, sensory, and motor perception, that impairment in one of these domains may signal the need to inform the MTO, because these are all things that are essential for driving. However, cognition is going to be our, that's our area that we need to make sure we're looking at quite carefully because of the increased risk. So here's a ton of tests on here. I'm sorry that I've crammed so much on here. And I've included references for all of these things. So your Trails B 3 and 3 error, that has been well established in the stroke population. One thing I want to highlight is that speed might actually be more predictive. So if you've got a patient that's on the borderline, but their speed was good and they're worried about their errors, that might make you feel a little less anxious than the other situation. Food for thought. Your classic MVPT, the original, 36 item, that has also been used with stroke. It's shorter. A lot of people have it, a dusty copy in their OT gym that's available. There's some research on that. It's not as good as Trails B, but it's a less language dependent assessment that can be useful. So that's something to consider. The UFOV, I don't know if anyone has used this clinically. It's a great assessment. I find it incredibly hard personally, but it's a great assessment. And there is some good research, especially in that subtest 3, where if no one's familiar, it presents a field and there's a car or a truck in the middle, and they present one of those, and then they present another stimulus in the periphery, and then there's distractors among them. And so you have to identify what was the vehicle that presented in your central vision, either the car or truck, and then identify and then where the other vehicle was among distractors. It's very challenging, but it's a great assessment. I can see why it's so predictive. And if it's available to you, I'd recommend giving that a try. And I've included some field some cutoffs as well. Insight and problem solving, so important. And I always say this to my students: I'm much more concerned about the patient that has some mild impairments and no insight than a patient who's doing pretty well but has no insight. That is a huge decision. That's going to be the decision that's going to have them the ability to check in with their symptoms and determine if they need to abstain from driving, report symptoms, that sort of thing. So insight is huge. And then the last thing I wanted to point out were some driver batteries. I've listed the prices and places to get them if you'd like to use them. I don't personally use them because they take a little bit too much time for what I need in acute care, but I wanted to also bring these to your attention. Oh, do we have another Q&A here?
Yes. Do you have any thoughts about use of the Kingston Standardized Cognitive Assessment with Drive Score?
Oh, that is something that's new to me. I haven't come across that in any of my stroke related stuff, but thank you very much, participant, for sharing that. Can you write that down for me? I'd like to follow up on that. Thank you so much for your question, but I'm not familiar with that one. Okay, next slide. Okay, so visual screening is another tool that's available to you. Your classic Snellen eye chart is very easy. You set it up 20 feet from the patient. Snellen is something that's been in existence for a long time, so you can actually find this in the public domain and just download it. The driver standards for Ontario is you need to have 20/50 acuity and then 20/30 for commercial drivers. This is, again, a pretty straightforward assessment. And as you read down the first part where they make a mistake, you back up, and then that's their visual acuity. Visual field testing is a good way to check for visual fields using confrontation testing. I have a link here. I won't go over it in this presentation, but this link for this YouTube provides a very good demonstration of how it's completed. In a nutshell, it's just presenting stimuli to the peripheral of someone's vision and checking to see if they're able to identify them as accurately as you can. And you're just provided your visual fields are normal. So check out that video. The Ontario driver standards say that you need to have 120 continuous degrees along the horizontal median and then 15 above and below the fixation point. And then you also need to have no diplopia within 40 degrees of the fixation point. It's important to note that there is a vision waiver program for those who cannot meet the vision standards. If they have a sufficient assessment by an optometrist or ophthalmologist that says they are able to demonstrate what's required, having a field cut is not a definite no-go for driving going forward. There's drivers with monocular vision, for example, that are able to meet driver standards. But generally myself and my skill set in acute care, if I'm detecting a visual impairment, that's a report to the MTO for me. I'm usually more likely to report those. I don't have a way to complete a very specific detailed assessment. It's very sophisticated to do it detailed. So usually I'm going to be sending a condition report in that case. And finally, for motor screening, it's less concrete about what standards are for motor function after stroke. They say that, if there is loss of functional ability, it could warrant a report. Some things to consider is the functional implications of the motor weakness. How are they doing with their ADL, for example? The rapid pace walk is something that's available, and that includes doing a 10-foot walk one way and turning around and doing a 10-foot walk back. And if it's greater than 9 seconds, there's a 3 times increased risk for a motor vehicle collision. Also, having reduced trunk and a neck range of motion is definitely associated with increased risk for trexels or accidents. So that's another thing to consider. Taking a driver history is important. I find this can be a little bit more helpful in the context of patients with chronic conditions, or if they're more in the elderly population. Is it possible that they had risk for driving previously? And so getting some information about their driver history, sometimes from the family, can be a little bit easier to get. That could be something that might inform your decision making. And also the functional assessment results from other members of your team. Maybe there's things that are found by your other team members that are very useful. And I find that there's been many times where there's been a patient that I've seen and I've, spoken with one of my colleagues that have said, oh, you know what, I saw this, and it'll kind of make me go back. So use your team. We're there for a reason. And I think that that's a very useful way to make decisions when the team is involved and everyone can provide feedback, because everyone has a different specialty that they can contribute. So when there are no risks identified in screening, this is the easier one. I usually make a brief statement in the chart and make sure I'm very clear about what I've informed the patient and what I've informed the physician. In interest of time, I think I'll skip over this and let you read it another time. So this is the more tricky one. So if there are risks identified in your screen, let's say you've assessed the patient and you think, I'm just going to do trails B. I think that's the thing I'm most worried about. These other things I'm not worried about. I've seen everything else in my assessment seems, within normal limits. If there is, let's say they do the trails and they take too long, I want you to always think about, are there any known factors that could have influenced the results? There's always unknown factors like measurement error, and maybe the patient was just tired that day. People don't always score the same on every test. But try to think about, is there something that could have explained the results? Were they excessively nervous? Were there significant distractions throughout the assessment? Was there a language barrier you didn't detect? See if you can try to answer any of those questions. But if you still feel like there were some factors that might have influenced the results, so try to think, is there a way you can do some more assessment? That's always the best. Try to get more information. Sometimes we don't have that luxury. And as you'll see here on the slide, if you're not able to complete further assessment, maybe this is when you think about, okay, how is their insight? If I think that part of my assessment was limited because of their, English as a second language, and I had a language barrier assessing them, do they have a family doctor that's present? Does their family doctor speak their language? Could we close the loop that way? Because we don't want to be making decisions based on measurement error or a bad use of an assessment. I mean, it's a riskier option, of course, but if your gut tells you that, I think that, I just caught them at a bad time, or there's something up, that is something that you can consider. Speak with your doctor, speak with your team, but that's something that you can consider. But if you're not able to, feel like they are able to wait to see their family doctor, you have concerns that they might drive, maybe that's when you'd send it possibly a discretionary report. Say, look, I did this assessment, but, I think they actually had more challenging with the English alphabet than I expected. And then you can, then you're just putting it to the ministry, letting them decide. If you've completed the assessment and you feel like it was a good assessment and you found some impairments, this is when we need to consider sending a condition report. And again, you have the option of sending a mandatory report, a discretionary report. But after all of these situations, we need to be making sure that we're providing counsel for driving restriction and a supportive plan for community mobility. And again, here I have another example of what we might do for some documentation. When you're completing a condition report, these are the criteria. So they need to be a risk for a sudden incapacitation or recurrence for stroke, or they need to have a CVA that's resulting in physical, cognitive, or visual field impairments. These are the criteria for reporting. So let's go through and talk about the form. So what I do for this is I just place that ID sticker there on the first part. Part 2 is just completing your information, including your signature, identifying your role, how you can be contacted, and indicating if that you've informed the patient of the report, if you wish to be notified, and if you're okay with your report being released. This is for if you're completing a mandatory report. So in this case, this would be when the physician, nurse practitioner, or optometrist is completing the report, and they'll be indicating what characteristics of the CVA necessitated that report. For the discretionary report, this is just the bottom section of the last page. It's very small, and this is where you can just put in, so if you're an occupational therapist making the report, putting in some information here about the patient presentation, this will then be viewed and compared to the driver standards. But I've heard that generally, if you're going to be putting in a report that includes anything about cognition, it's generally going to be a functional assessment that's recommended, or they'll be considered for a functional assessment. Do I have another question?
You do. How do you factor aphasia into your decision making?
Yes. So in my opinion, I think that it's especially if it's going to be using like trails, that's a really challenging thing, because if they have aphasia, are they also going to have apraxia? So in my opinion, if they have aphasia, they're likely going to be going on to some further rehabilitation, see what their response is. But I think that if you're not able to complete a reliable assessment, and there's barriers, and we already know of some impairment like aphasia, we might need to be sending a report and be honest about what that you could send a discretion report it's aphasia, difficult to assess, cognition and that. So I think it's a real barrier, but that might be a way to address that. So after the report is sent, drivers are usually notified within 10 days of the outcome. So again, the option is to ask for more information, or it will be just a suspension right away. Again, they assess them against the National Safety Code, this driver code. And if they're not able to meet it, the license is downgraded in the case of like an AZ license, or it's suspended. And if information is unclear, they will ask for more information, and that can actually reverse a suspension. After a report is sent, especially if there's residual deficits that are cognitive, it generally triggers a request for a functional assessment at an MTO approved center. They are 3 to 4 hours in length. They're complete with an OT and a driving instructor. They do in-clinic on-road. As you can see, it costs between $400 to $800. And after the assessment, a report is compiled and sent to the MTO. And again, the MTO reviews that and then makes a decision. So again, the MTO is determining, even though they have that report, the MTO is reviewing that and making the recommendation. Oh, do I have another question? Why wouldn't you involve SLP? Oh, yes, absolutely. Yes, that was an oversight. Yes. I've had many, I do a lot of joint assessments with SLP, and one assessment that I love to do with SLP is the kettle test. I find it's a wonderful performance-based assessment that can be very helpful. So again, yes, that's an excellent point. Thank you, participant, for that. That's an excellent point about the aphasia and driving. So if the license is suspended, it can be appealed to the License Appeal Tribunal. So the hearing is with a legally qualified medical practitioner. I think it's generally a doctor, but I think there possibly might be OTs. And again, the ministry is trying to demonstrate that they have the impairment. You usually have a hearing within 30 days. And if the license is suspended and a patient continues to drive, there's fees of $5,000 with repeated offenses, increasing to more fines and even imprisonment after I think it's after 3 or 4 times. So these are the consequences and options after a license is suspended. Sorry, I'm racing through here because I've had poor time management. But I'd like to get to a little bit of an interactive case discussion. So we will see if I've got 4 here. We'll see how we can do it. I don't have a time commitment. I know I want to respect people's time, but if we go over, I'm fine with that. So I'll have people read case 1, and I'll invite Tina to put up the poll. So I'll read it while we're waiting for the poll. So Mr. Singh has had a stroke with mild residual deficits that are expected to recover. He has excellent insight and follows therapy recommendations. He's going home from acute care. He will be receiving outpatient OT and PT. The patient's spouse will drive him to appointments. What do we think? Okay, so it looks like a lot of people are choosing that inform the patient of the 30-day driver restriction. Just in the interest of time, I think I'll start responding to people. I think that's what I would do. There's always exceptions to this. But I mean, I deliberately chose things where there's no really wrong answer. All of them could be, you could entertain all of them, but I would agree. I think we expect that he's going to get better. We expect he's going to be compliant. So I recommend that he not drive for 30 days and follow up with the family physician, and hopefully we'll get some more information after he attends his outpatient. Okay.
April, there's one more question that came in before you move on, if you're okay.
Can physicians submit a discretionary report? Yes, physicians can also do a discretionary report. Yes, that is correct. Okay, case 2. Mrs. Brown suffered a stroke with significant residual deficits. She has completed her 35-day inpatient rehabilitation stay and will go on to further outpatient follow-up. The team does not think that recovery of her driving abilities will occur anytime soon. What do we think? Okay, now that we've got, just over 50% of the respondents here. Yeah, this is one that's also a bit tricky. I think in this case, I'd send the condition report. I think that completing driver screening could kind of, it could help to inform your decision. But I think that if you guys are already thinking, the team is already thinking that there is, a low risk that she'll be able to return to driving, an MTO report. I agree. That's what I would do. Okay, let's go to the next case. Ms. Lee is attending outpatient therapy following a stroke 10 days ago. She has mild deficits and the team suspects she's unsafe to drive. At the second appointment, you notice that Ms. Lee has driven herself to the clinic. When you address this with her, she initially denies it, then insists she will continue to drive since she's not driving far. What do we think? I can't tell you how many times this patient has said, well, I'm not driving far. Okay, now that we've got, we're getting closer to, oh, there's a little neck and neck there. Maybe we'll wait until we've got just a few more. Okay, so so this is again a difficult one. So I think what I would do is I'd send a condition report, because I think that this means that there's some risk here. We already have a suspicion. I think that completing driver screening can be useful, though, if you want to feel like you have some reasons to substantiate your report. I think that there's a role for that as well. But I think I'd be more inclined to inform the MTO or send a discretionary report, speak with the doctor about that.
April, there's one more question that's come in is, do you have a lot of time in acute to focus on driving assessments?
Yes, so it's not, I don't have a lot of time, honestly, and I'm sure everybody who works in acute would say the same thing, but I'd rather do something than nothing. And so I deliberately choose screening tools that are quick and easy. And if I'm not able to satisfy that I've closed the loop safely, that I've made a good recommendation, or that I don't have enough information, I'll do what I can to close it other way. So if I can't assess it, I might be more likely to send a discretionary report and say, hey, the patient discharged. I saw some impairment in my functional assessment. They're not going for follow-up. You might need to do it that way. But I think that I try to doing something is better than nothing in almost all cases. It's a legitimate challenge and something that I'm doing my PhD on to see if I can figure some of this out. But yeah, it's absolutely a challenge. Okay, last one. Mr. Romero had a small stroke. There's no obvious residual deficits that were uncovered in the functional assessment. The team has determined no further therapy as follow-up is indicated. He's now medically stable and ready for discharge from acute care. What do we think? Okay, so this is one that I think what I would do in this case is that I probably would complete driver screening. So what I know from this case is he's got no obvious residual deficits in my functional assessments. I've found this out the hard way, of course, which is when people do our best learning, is that I've seen them and they seem fine. And then I go do their MOCA and I go, oh shoot, they've got some problems. And so if I'd only done some just kind of cursory functional assessments, I'd probably go on and do some assessment, make sure check that MOCA, and I'd probably be doing some kind of driver screening, maybe the trails perhaps, just to say I've tried something. I think that there is, it is appropriate that they are informed to not drive for 30 days and follow up with their family doctor. But I also think that it's probably also appropriate to do some kind of small assessment. And sometimes you don't have the luxury, but these are all ideal circumstance with a very, superficial case. It's not a real patient in front of you. But I think in this case, I would try to do some kind of screening. So I think that brings us to the end. So any questions and any reflections about that knowledge test that we did at the beginning? So I think as I recall, one question was true, false. If there was, maybe we should go back to that.
Yeah, April, would you like me to actually relaunch it so people can
Yeah.
answer it again? Or
Yeah,
would you like
please,
to?
yeah, relaunch. Yeah. Can we save the results from last time as well?
Yes.
I'd love to see the pre-post. I'm researching all of you. You're in my study now.
Our,
Oh, it's coming in now.
yeah.
Okay, we've got about half of our participants here. So we've had a little bit of movement on these here. So for number one, following stroke or TIA, a patient can't drive for 30 days. So this is false. Following stroke, a patient can't drive for 30 days, but not necessarily also for TIA. So the correct answer here is false.
So April, I can
Yes.
let you know that last time only 25% of people chose false. So
Okay.
so that's an improvement to 41%.
Yes, please give us some live stats here. Yes. And then number two, a condition report must be sent to the MTO after a patient has a stroke. And that is false. It does not have to be. There needs to be a risk of sudden incapacitation, sudden recurrence, and have residual deficits, physical, cognitive, or perceptual deficits.
Okay, so again, for that one was 53% that chose false the first time.
Okay, we made some movement. And then number three, doctors, nurse practitioners, optometrists, and OTs can send condition reports, and this is true. We can all send reports.
Okay, so actually the first time it was 92%.
Okay. And then the last question, condition reports sent to the ministry result in license suspension. And that is false. They don't always, not every condition report sent results in license suspension. Sometimes they just ask for more information and it is reinstated. So the correct answer is false.
Mm-hmm. So originally it was 64%.
Okay. All right, I'll open up the floor. Does anybody have any questions? I apologize, I've grossly gone over the time.
There are some questions in the Q&A, April.
Okay, great.
So I can read them to you.
Oh, I can see it.
Can you see them? Okay.
Yes. Do you know how similar the rules and regulations are for stroke and TIA? So the CCMTA guidelines are national. The driver standards are provincial. So there is likely going to be some similarity, and the 30 days for stroke is, I believe, across the country, but the specific driver standards that are being, although the MTO has their own standards, but I think they are based on the CCMTA. I have a suspicion that they're quite similar, but reach out to you can find all this information on our Ministry of Ontario website. Check your BC one. Will we have access to the slides? We'd like to develop a driver's package. Yes, the slides will be available, and please send me an email. So my research is developing a practice resource for addressing driving after stroke. My email's on all the slides, and the next phase of my thesis is actually, piloting and testing and getting some co-creators even from different therapists. So please reach out, because I have something that I've been working on for a few years that I'd be happy to discuss and share with you. What happens if the patient does not have a family? Oh, it's moved. What happens if the patient does not have a family doctor to follow up with? So this is really challenging. So for us, we have a secondary stroke prevention clinic attached to Grand River Hospital. So sometimes I'm able to close the loop that way if they're going. But what it might mean is that you might have to send that report. So if I have a suspicion that if they're not able to complete the forms, they'd probably be more likely to be requested to do a functional assessment. And what happens in the time between the discretion report being sent and the patient receiving the letter. So I always advise patients that after the letter is sent, presume your license has been suspended. It is not determined yet if it's a discretionary report, but operate with the assumption that it is suspended, and that carries fines and certainly there's different coverages for your insurance as well. If you had an accident and your insurance adjuster did a deep dive and saw that you were advised not to drive, you will lose insurances. So that would include income replacement. It would include some transportation expenses. There's one other benefit you don't get if you've been, if you've ought to know that you shouldn't have been driving. You can't profit from, driving against medical advice, which is illegal, or driving with a suspended license, which is illegal. Does the MTO always send a response following a report? Yes, they should always be sending, provided the address is correct, they should always be sending a report in the mail. I work at a community setting where I see a number of clients who've had their license suspended while they were in hospital. They often want to know when they're ready to attempt to get their license back. I typically do screening assessments and provide education about the process through the MTO, but I find it really challenging to know when they're ready to attempt return to driving. Oh, I do too. I think I might have a resource. There is some research that has been done that makes recommendations for pre-driver screening prior to functional, participating in a functional assessment. I think I found something yesterday. So please, Amanda McKinnon, send me an email. I think I saw something recently. There is some research about pre-driver screening before they are ready to even participate in a functional assessment, I do think. Can you quickly review the 3 and 3? So 3 and 3 for the Trails B, if it takes them greater than 3 minutes, that would be considered a fail. If it takes them if they make greater than 3 errors, that's also considered a fail. So independently, they're fails. And if it's 3 errors or greater and 3 minutes or greater, then that's like even more risk. And make sure that when you're doing the Trails B, you give that you're very careful with following instructions. This has happened a couple of times where there's been people that, oh, the patient made a mistake. And then with the alternating back and forth between numbers and letters, they're systematically wrong at, many times if you don't correct them from the beginning. If they miss that A, they're going to be systematically wrong all along. So make sure that when you're doing it correctly and identifying all of the errors as they make it, and it drives up the time, which, affects their performance on the test. Okay, did I get all of them?
There's one
more.
Just as a comment, as an outpatient OT, it is so much better for us if the patient has had any possible residual deficits if an MTO form has been sent. Patients will then consent to further cognitive assessment. Often, if they haven't been reported, they don't want to participate in cognitive screening if the fear is being reported at the time. That is a very legitimate concern. I hear you, and I think that there's probably many people who share your opinion, and it's maybe something that I would recommend discussing with your acute care therapists. And what we actually developed, because this is certainly what happened, is that so we actually have a handout, we call it our letter of understanding, and it was our outpatient therapist's idea, and I thank her for this all the time, that we actually write very clearly on a letter. We say, you have had a stroke. Best practice dictate you cannot drive for 30 days. 30 days is not the time when you magically come back, automatically return to driving after 30 days. You need to be symptom-free. You need to be following up with your family doctor prior to returning to driving. And I have them signing it, and I have it, and it says that, I understand that I've been informed not to drive. And I think that this has helped, because I think that it can happen in both ways, where the outpatient therapists are either the bullies for bringing up driving, or they're viewed as these heroes that are going to give them back their license. And then when they can't, that breaks a lot of broken expectations for the patient. And it's a very challenging position being in the outpatient setting, because there's, you're often the last stop. And, you know, and when I refer to my outpatient colleagues, I know they're going to good hands. I really trust and respect the therapists I'm sending them to. So I understand that it'd be very challenging from the perspective of you're the last stop. But I recommend having a conversation with your acute care therapist, because we need to find out a way that works for all of us. So collaboration is almost always the answer.
Okay, thank you. Thank you, April. This has been an awesome presentation, and also want to thank the audience for all of their active participation. So an
Yes.
evaluation link has been sent out. Please consider filling it out. It's very, very short, and it really does help us plan our education. We have 3 remaining sessions in this series, and we will be welcoming Dr. Tenen on November 24th, so 1 week from today, to speak on mental health issues following stroke. Have a great afternoon, everyone.
Thank you so much.